Good evening, seniors and friends. I know that after these many lectures, we need to know how to live 100 years before developing, because there are so many lectures, heart failure and ischemic heart disease and so on. And it is also good that I should not stand between the good dinner and this lecture, so that, stress is also reduced. But the paradox of the coronary artery disease is that coronary artery disease deaths which are down by half, but heart failure is almost triple. That is something worrisome, because the burden of the heart failure which has increased. And another problem is we can see the decline in the mortality, heart failure mortality. But again, after 2011, the mortality in heart failure has started increasing. And HEPREF, MREF and HEPF. If the pro-BNP level, anti-pro-BNP level is very high, as we can see from this slide, last bars, if we can see, then mortalities, again, it is almost similar. So heart failure with MREF and PEF, that is the preserved ejection fraction heart failure. So persistent high anti-pro-BNP level, it also gives a lot of mortality to the patient. And as a result of which, this is the classification, HEPREF, MREF and the HEPF. This is mainly for the MREF and the heart failure with the preserved ejection fraction. Treatment of the MREF, that is class 2B indication for the MRS, and American, European, both they have agreed for that. But in case of HEPF, we know that American guideline class 2B, but European guideline still it is not saying anything. And this is important, that is variation in the incidence of the rate of the deaths by the cause and continuous left ventricular ejection fraction. If you look at this slide, as the ejection fraction which increases, the non-CV death which increases, but ejection fraction is on the lower side, that is the HEPREF, the sudden death which has increased. And obesity, which increase the risk of the CV events in the absence of metabolic abnormalities. And as previous lecture, this was regarding the CKD and the heart failure, because albuminuria, which is very, very important. And this is mainly our focus is on MREF and the HEPF. There is the high unmet need for the patient with the heart failure with LV ejection fraction more than 40%. Including the high hospitalization rate and the mortality, we know that now rising prevalence of the HEPF patients, there is poor prognosis too, and they need hospitalization, and the recurrent hospitalization we see in so many patients. The life expectancy is reduced. For example, patient is having diabetes, 6 years is reduced, diabetes with CV disease 12 years, but CKD, that is 16 years it is reduced. Coming to our important molecule, that is finerenone, but fidelity, the primary analysis which showed the significant risk reduction in the CV and the kidney outcome with the finerenone. There was 14% reduction in the CV morbidity and the mortality, and 23% reduction in the CKD progression. And whatever the effects which was seen with the finerenone, that was irrespective whether patient is on SGLT2 inhibitors or GLP-1 agonist or not, it was benefit was reported. In this fidelity trial, it was found that finerenone, actually the BNP level which was very low compared to those who are on placebo, and troponin level was also found little less. So finerenone, which improved the cardiovascular and the heart failure outcome versus the placebo in the patient with the CKD in type 2 diabetes. And after this, of course, this was mainly driven by the reduction in the hospitalization of the heart failure. And as a result of which, we know that in type 2 diabetes with CKD, SGLT2 inhibitors, class 1A, and the patient is having diabetes and CKD, finerenone was recommended to reduce the risk of the heart failure hospitalization, which was class 1A. So this is now proven for the diabetes with CKD. But this is another recommendation, that patients with diabetes, they are routinely screened for the kidney disease by assessing the eGFR, and we have to know the USCR in this patient. And we know in MREF and the HepF patient, the SGLT2 inhibitors, which is very, very important molecule, but still there is residual risk, which is there. If you look at the Emperor Preserve trial and the Deliver trial, I mean, residual risk is still there. So again, I will say that it's an unmet need. How can we further improve that? There are limited approved treatment for the HepF patient and MREF patients, but only few, I think, diuretics, the SGLT2 inhibitors. RNA again, it is MREF patient, which is important, but still we have not the full period treatment as like in HepREF patient. So this was the trial, which was the fine arts heart failure study. The patient having the symptomatic heart failure, ejection fraction 40 or more than that, hospitalized, recently hospitalized, high natriuretic peptide levels and the structural heart disease. And here the finerenone was given in little high dose compared to this previous Fidelity trial and the Figaro trial. Here it was increased up to the 40 milligram according to the eGFR of the patient. And the randomization timing that is relative to the most recent worsening the heart failure event and the LVEF status on the randomization means the 20% of the participants were randomized during or within 7 days of the worsening heart failure events, and the LV ejection fraction status, as we know that 45% there between 50 to 60, less than 50% it was in 36%, and more than 60 in the nearly 20% of the patients. And the primary endpoint, that was CV death and the total heart failure events, it was in the favor, and the 16% reduction was found. Rate ratio was 0.84. So, I mean, better results with the finerenone, and it was not related to any male or female. It was equal whether patient is on the SGLT2 inhibitors or GLP-1 receptor inhibitors. This is very important slide that hyperkalemia and hypokalemia both are very, very important in any patient, but we know that hypokalemia, which is more dangerous than the hyperkalemia, and by putting the patient on the finerenone, hypokalemia was less. Though we have to be careful when we are putting any patients on whether it's steroidal or non-steroidal MRAs, we have to check the potassium, but here the chances of the hypokalemia was less when the patients were put on the finerenone. Comparison of these three molecules, spironolactone, eplerenone, and the finerenone, we know that spironolactone usually we are using for the resistant hypertension because it has long effect, it lasts for the 3 weeks. Eplerenone usually used in the acute myocardial infarction status, but finerenone is the molecule when the chronicity which comes into the picture, where finerenone which works very well, and as a result of which it is the treatment of the choice when the patient is having the CKD, patient is having the heart failure, MREF and HepF, because when the chronicity which comes into the picture, I think finerenone which works very well because it has equal effect on the heart and the kidney compared to other two molecules. And these are the changing landscape of the heart failure pharmacology. We can see the various trials. In the previous trials, RNA was not available as SGLT2 inhibitors, they were not available. So this was the fine heart umbrella program, and pulling all this data together, we can see that primary endpoint, that cardiovascular deaths, which was reduced, cardiovascular death, including the undetermined death, which is reduced. So the patient is having the MREF and the preserved ejection fraction. So we have one additional treatment. Now question arises, the why death is not being much affected. If you look at the previous trials of 90s or 2003, and you look at the trials of 2021, already mortality has already reduced by the 50%. So it is very difficult now for any trial to show that there is great benefit in the mortality. Another subgroup analysis with the finerenone was that significant benefit which observed within the 30 days of the initiation of the finerenone, which we can see in this trial, and estimated long-term benefit of the finerenone, that is, if the finerenone which is prescribed to the patient having the MREF or the HepF, we can see 3.1 year lifespan the patient may get. So survival free from the primary endpoint of the 55 years. This is the estimated long-term benefit of the finerenone. And as I told you that finerenone has got a combination with the SGLT2 inhibitors. I think in the future, maybe in the heart failure and the CKD patients, Barriers to implementation, according to the doctors, usually when the knee jerk is that whenever the patient is on MRS, immediately we stop first in the majority of the patient on this survey. And hypotensive patients, if you look at this diagram, that patients are having the blood pressure in the range of 105 and 115, there was no much difference in the blood pressure. Means the patient is having the blood pressure on the lower side. It is not going to create much of the hypotension. So that's why also it is going to be very effective. So rationale of this molecule, despite the availability of the several therapeutic options in the heart failure with mildly reduced and the HFpEF patients, including SGLT2 inhibitors, but still there is unmet need. Steroidal mineralocorticoid antagonist reduce the morbidity mortality in the patient with heart failure with reduced ejection fraction, but their efficacy in the MREF and the HFpEF patient has not been definitively established. So this is the important trial, fine arts heart failure trials, where the finerenone, one more molecule that we can say now 3 pillars for the treatment of the heart failure with the preserved ejection fraction. So I think in the guideline future, we may see the finerenone, whether it may be class 1B. And another, there's semaglutide, because all preserved ejection fraction, whether it is obesity and obesity related, it's a metabolic disease. So semaglutide and the tirzepatide, which is altogether, it's a different topic, but still I think these are the two important drugs I think we are likely to see in the future guidelines where the patient is having the MREF and the HFpEF. So take home message is, whatever it is that when the heart failure comes into the pictures, we can say it's urgency of doing. And why we are not getting the good result? Because we need to have the right way to design the trial, to find the right patient, then right time also when to give the drug to the patient. We should have the right composite and non-composite endpoints, and the endpoints to have the enough power to detect what we want to detect. And that is the story. I think this is the one more molecule. There are 3 pillars for the HFpEF. Thank you very much.